Bismillahirrahmanirrahim. Today's lecture is about strabismus. It is also called squint, and it is also called bhangapan ya tirapan in Urdu. Paralytic strabismus or non-concomitant strabismus. This is due to limitation of ocular movements, and the angle of deviation varies in different directions of gaze. Causes. Number one is ocular nerve palsies, and number two, ocular muscle restriction. Ocular nerve palsies, the causes may include number one, idiopathic. This is the major part. More than 50% of the cases are idiopathic. Then is vascular disorders, diabetes, mellitus, and hypertension. This is the next most common cause of ocular nerve palsies. Then there is trauma, tumors, inflammations, infections, raised intracranial pressure, or congenital. Number two, restrictive causes of paralytic squint. These include thyroid eye disease, pseudotumor orbit, orbital trauma, orbital myositis, and muscle tumors like rhabdomyosarcoma. Common features of all types of paralytic squint. The first and most important complaint of the patient is diplopia, that is double vision, and it is very annoying. Number two, restriction of ocular movements in the direction of action of the muscle involved. Secondary deviation is greater than the primary deviation. Now, what is primary deviation? Primary deviation is the angle or degrees of deviation when the normal eye fixates. What is secondary deviation? It is the angle or degrees of deviation when the affected eye fixates. It is always larger in paralytic squint. Abnormal head posture. Investigations, routine investigations, and special investigations according to the cause. Treatment. First of all, treatment of the cause. Then we have to treat troublesome diplopia, which can be done by patching the eye, and some patients require binocular vision and do not tolerate patching, so prisms can be incorporated in their refraction, or even botulinum toxin can be given to the antagonist muscles. We wait for 6 months at least for spontaneous recovery. If after 6 months there is significant squint and diplopia, squint surgery is done. Third nerve palsy. In third nerve palsy, it is easy to remember that the eye is in down and out position. Down because the superior rectus is not working, and abducted because the sixth nerve pulls the eye laterally. There are two types. Number one is complete. Number two is incomplete or pupil sparing. Complete palsy with the involvement of pupils is usually due to surgical causes, and these causes are usually life-threatening. So MRI brain is essential in this type of palsy. The pupil sparing third nerve palsy is usually due to diabetes, hypertension, or idiopathic causes. And it is also called medical third nerve palsy. There is also loss of accommodation and ptosis. This picture shows a patient with left third nerve palsy. Figure A shows that there is ptosis and the eye is in depressed position. Figure D shows that there is defective elevation. Fourth nerve palsy. It supplies the superior oblique, and superior oblique has three functions: depression, intorsion, and abduction. It is the most difficult nerve palsy to diagnose out of the three, as the signs are subtle. The chin is depressed due to loss of depression. The head is tilted towards the opposite shoulder due to loss of intorsion, and the face is turned toward the same side due to loss of abduction. In order to diagnose a case of fourth nerve palsy, Park's three-step test is done. First step, check for hypertropia in primary gaze. Step 2, observe increase in hypertropia on opposite gaze, WOOG, that is worse on opposite gaze. Number 3, observe decrease in hypertropia on opposite head tilt, BOOT, boot, best on opposite tilt. The diplopia in fourth nerve palsy is especially troublesome when looking down, that is in reading and descending stairs. This is a picture of a patient with right fourth nerve palsy. The head is tilted towards the left. There is chin depression and the face is slightly turned towards the side of the lesion. Sixth nerve palsy. It is the most easy one to diagnose, as there is limitation of abduction and the eye is deviated inwards. The patient complains of horizontal diplopia that worsens on same gaze and improves on opposite gaze. The person turns his face towards the affected side to avoid diplopia. This is a picture of a patient with right sixth nerve palsy. In slide B, one can clearly see that the right eye is not abducting. This is a summary of all three nerve palsies. The first one is third nerve palsy, in which you can see the eye is depressed and there is ptosis and there is abduction. That is, the eye is in down and out position. In fourth nerve palsy, you can see the left eye is hypertropic. In sixth nerve palsy, you can see that the eye has deviated inwards due to loss of abduction.